You don't know me. Probably never will.
But I need you to do something for me.
Something that could literally
change everything.
You'll never get a thank you card, and yet I need you to do it.
And if that weren't enough, I need you to do it as soon as you are able to.
If you do this for me,
I'll do it for you.
And for every single person you love.
Deal?
This is our shot to leave COVID behind.
Good afternoon, everyone, and welcome to our breakout session, Which Comes First? Why it is so hard for housing and healthcare to work together during pregnancy. We have an amazing panelist with us on today. Representing from the DC Health Office of Health Equity, we are joined by Dr. Anneta Arno. Also representing from the Community of Hope, we have with us Abayea, Pelt. We also have joining with us Sara, Cartmill. Also joining us today, we have Calvin Williams, and also as our panelists, we have Miss Jamilah Muhayman. Thank you, everyone, for being present with us. Now at this time, please welcome to the virtual stage, Miss Abayea Pelt.
Good afternoon, everyone. So yes, the title of our presentation is Which Comes First? Why is it so hard for housing and healthcare to work together during pregnancy? And we're going to talk about an innovative program that we have at Community of Hope, where our organization has robust services on our health side, and we also have robust services on our housing side. And we are attempting to work together, bring them together, and integrate these two sides of our organization. So we're going to talk about how we've been doing that and the impact that we're hoping that it will have on the people that we're working with in their pregnancies. So what is the connection between the experience of homelessness and the perinatal period? So we know that the prenatal period is a critical time in the health of a mother or birthing parent and their child. During pregnancy, high levels of stress can increase the chance of having a premature or a low birth weight baby. We also know that Black and Indigenous women are 2 to 3 times more likely to die from a pregnancy-related cause than white women. And we know that Black women, women of color, are overrepresented amongst our homeless population. And we also know that the rate of infant mortality for Black babies in DC is 3 times that of their white peers. And so in thinking about these factors, what we recognize is that stress, trauma, and instability impact health and pregnancy outcomes. And so to address that, we want to look at services that we can provide. So our approach at Community of Hope and our goal is to improve health and eliminate inequities in health outcomes in under-resourced communities in Washington, D.C., to improve maternal and child health, particularly for families of color. And we do that by providing primary medical care, including prenatal care, care for children and pediatrics, and as well as emotional wellness services. And then we have an entire suite of additional services that help families during this time in their lives. So that includes centering pregnancy, which is a group model of prenatal care. We have labor and delivery services with our team of midwives and doulas. We have perinatal transportation services. We have early childhood home visiting programs. And one of the key roles in all of this is that of our perinatal care coordinators. So our perinatal care coordinators begin working with pregnant patients when they enroll in our prenatal care. They are embedded in our health team. They work with the families that are assigned to them. They screen for depression. They screen for intimate partner violence. They get an understanding of the risks present in a person's life, as well as the protective factors. And so in thinking about how we could integrate our services, my colleague, Sara Cartmill, will talk more about this, but the idea is that for families who are experiencing homelessness or who are recently housed or who have experienced homelessness in the past and are also going through pregnancy or have a newborn, there can be a way to bring this perinatal care coordination to them to help to increase the likelihood of healthy births and healthy pregnancy outcomes. And so with that, I will turn it to Sara.
Thank you. Can we go to the next slide? So my name is Sara Cartmill, and I'm one of the senior directors of housing with Community of Hope's housing programming. We provide an array of supportive services to families at various stages of either being at risk of or actually experiencing homelessness.
I'm sorry, I'm going to have to reload the presentation.
Okay, no problem. I was going to just point out on a map of the city, we had our clinic locations, which I was going to touch on briefly before I shifted over to housing. So our housing programming supports families who are living with other family members, but may be at risk of losing their housing through something called homelessness prevention. Here's our map. So this is the map of the District of Columbia. And briefly, before I go to housing, I wanted to point out our healthcare locations in the city. We have 4 locations. In Southwest DC, we have the Conway Health and Resource Center. Moving a little bit north, we have emotional wellness services at the Commons at Stanton Square, which is a location that we share with Martha's Table. We have in Northeast DC, the Family Health and Birth Center. And then in the Adams Morgan neighborhood of Northwest DC, we have the Marie Reed Health Center. So those are the locations where we have all of our healthcare going on. On the housing side, the only physical brick and mortar locations that we really have other than staff offices are 3 shelters. If you can just go back, one is the Girard Street shelter in Northwest DC, and then 2 shelters in Southeast, Hope Apartments and the Triumph short-term family housing. So I won't spend too much time on our housing programming, except to say that we kind of work with families along the continuum of the need for support from very early in the process, where families may be staying with family or friends, but are at risk of losing that housing. It's fairly temporary, and we have a homelessness prevention program that tries to work with families to stabilize that immediate situation and then come up with a longer-term solution. For families that have to enter shelter, we do have our 3 shelters, and then we have longer-term housing through rapid rehousing and permanent supportive housing. The one common thread in all of those programs is that all families are assigned a case manager who works with them. We track a number of unusual incidents across the families in our program, and one of the common areas of unusual incident is families that need to access emergency health services, either an ambulance or an emergency room or an unplanned hospitalization. And in looking at our reports around healthcare concerns, we noticed that there was a significant number related to pregnancy. And we kind of took a step back and thought, we have a lot of supports on our healthcare side for pregnancy. We have a very robust maternal and child health program. Maybe it's time to figure out how to connect our housing patients to those services. Right around the same time, we were going through a strategic planning process, and our board and staff were very interested in finding additional ways that we could start to integrate our housing and healthcare programming. And then the third leg in that stool, we also were fortunate to receive some grant funding for our housing services that was quite flexible and allowed us to dream and come up with a couple of ideas for pilots that we could pay for with the grant. And one of those was that we determined that we wanted to create a perinatal care coordinator, very similar to what we have going on our health side, who would specifically work with families who were pregnant and in one of our many housing programs. So that's what we set up. great, we come up with the title, we hired someone, we tell our case managers, start referring families, we're done, right? It wasn't quite that easy. And we learned that there were some challenges to collaboration, even internally at one organization. One of the very first barriers or challenges was just around language and vocabulary. I'll tell you right off the bat, many of our case managers didn't know what perinatal meant. So that was when we were telling people to refer to a perinatal care coordinator, and they're like, awesome, what does that word mean? Separately, in housing, we work with clients. On our health side, we work with patients. What do we want to call the people when we're both working with them? And there were so many acronyms. Housing is acronym rich. So is healthcare. They're not the same acronyms, and we all use a lot of shorthand. So we really had to take a step back and think about how to communicate more clearly with one another. Another area that we had to really think about and reframe a bit was our focus and priorities. In our housing programs, we don't just call our case managers, we call them housing stability case managers to really keep the focus on housing. And our job, our first job, is to make sure people are stably housed, and if they're not, to get them stably housed as quickly as we possibly can. It's a lot of work, it takes a lot of energy and time, and that our case managers are laser focused on that. Now we were asking them to step back and say, and for the people in the program who are pregnant, we need you to also think about this other thing. It's not like they don't think about other things, but this was a new focus and a real emphasis. So we had to keep reminding them of this awesome new service that we were providing, and we continue to remind people to this day to be sure to refer everybody to the perinatal care coordinator so that we can build in those supports. On the perinatal side, the focus is on working with the pregnant person throughout the pregnancy and then beyond. In some of our housing programs, if we're successful in moving someone out of a shelter, they may be gone from our program in 3 months or less sometimes. So on the perinatal side, we had to make sure that our perinatal care coordinator knew how long she might have to work with families so that she could really tailor her services to get in what she needed as quickly as possible. The last area was really around technology. One of the basic questions was, where do we put chart notes and case notes? In housing, we have 2 databases. In healthcare, we have a 3rd database. And initially, we had the poor perinatal care coordinator entering notes in all 3 places. And we decided after a very short time that that was not efficient. So we had to readjust and come up with a different plan for that. So in all of that, I will say the keys to our success, and we have been successful, and Jamilah is going to tell you about all the great things that she's accomplishing with our families, are to stay flexible. We continue to need to think about gaps in services or things that maybe where communication is tricky or we need to adjust something. And then on the housing side, just to continue to remind our case managers about this awesome service that's available so that we continue to send families to our perinatal care coordinator. All right, Jamilah, take it away.
So as the perinatal care coordinator, I am the housing perinatal care coordinator specifically. So I take on a lot of the same duties that the health-based care coordinators take on, but I provide that support for the family specifically in the housing program. And so here's a list of some of the reasons that the housing case managers would refer a family to me. So we have families that need support, securing a prenatal care provider. So as soon as they find out that they're pregnant, they don't know where to go. That's something I can support families with. I can provide education for families around pregnancy, childbirth, safe sleep, and infant feeding. We provide assistance with securing resources for the infant or the pregnant person, and then we assist with connecting them with transportation to get to all of their prenatal appointments. So the housing case managers are really well trained to support families with their housing needs, but a lot of times don't have the necessary background to support their pregnant families, and that's why they would refer to me. So they can be referred to me as the PCC. We give the families an opportunity to opt in to the PCC services because we know a lot of the families in the housing programs have a lot of things to consider. And so we want them to have the option to take on additional support person if they feel it's something that's going to be beneficial for them. Families that don't choose to work with me as the care coordinator still get some support from their case manager. And part of my role as the housing PCC is to provide that education and additional support to the housing case managers. And so we have some different ways that I support the housing case managers. First, I have weekly or daily office hours where they can reach out to me to get support with the families they're working with. They can contact me through the Teams chat. We have video calling and just a phone call or an email. And then I do what we call a monthly education tour. So I go to all of the housing staff meetings and I provide education on topics that are relevant to perinatal care. So we want to make sure that the topics are relevant, brief, digestible, and they don't assume any prior knowledge about perinatal health. Some of the topics that we've presented so far have included perinatal resources, the importance of perinatal care and testing, perinatal and early education, and there'll be more things to come in the future. We want to make sure that the housing case managers feel like they have everything they need to support their clients in a holistic way. And it's important to just reinforce that the knowledge that the case managers have about the perinatal period is not the same as me. So my goal is to help ensure that they feel educated. And next, we had an opportunity to talk to some of the clients that we work with, and these are some of the things that they shared with us about their experience working with the care coordinator. It's been good having someone that I can count on whenever I have questions. I thought it would be hard to have another person I had to talk to because I have a hard time opening up to people, but it's been good to have someone to call if I don't know something. The PCC has the information right there and it's always eager to help. Being in a housing program has been great. Being able to get my own place was really nice, and being more stable and having a housing case manager helped me feel less stressed. So I've shared with you a lot about what I do and how I feel about it. And we've also shared the voice of the client. And we've asked Calvin to join us to kind of share some thoughts from the perspective of the housing case manager. And so I'm just going to ask Calvin a few questions and he can kind of share with us his own experience. So Calvin, would you mind starting by just kind of telling us some of the challenges that families you've worked with may have experienced by adding a PCC to their support team?
As one of your slides just showed, the only problem that I ever come in contact with is my clients wanting to add a new case manager or, like you said, someone else that they have to talk to or explain their story to. But I believe your personality and your willingness to work with the clients and eagerness to reach out to them and let them know that you're there makes it a lot easier for those clients to open up and feel comfortable with asking you those hard questions.
Thank you. So as we know, you're a housing case manager, so your background in training is helping families with housing. What gaps in knowledge did you have to feel for you to feel comfortable talking to your clients about pregnancy, the ones who choose not to work with the PCC?
One major issue I always come in contact with, something that I personally aren't that good with, is just the delivery process, labor, things of that nature. I'm a male, so of course I don't know exactly what to tell them or how to prepare them or how they would feel. So those are kind of questions I lean on you for support or different things of that nature, just to kind of prep them of what they expect or what's going on, or, you know, just kind of to ease their mind about the whole process.
Thank you. And so what would you suggest to fellow case managers who are reluctant to work with a PC or to refer their clients to me? What's something that you would say to them?
Refer. You have been a tremendous help to our team. Like you said, we mainly focus on housing, and that's what I'm good at, and that's what I feel like I'm best at. So when, you know, we're starting to get questions about people, you know, their pregnancies and babies and different things, we don't really know which way to go because that's not our focus. You never just want to say, hey, I don't know. You always want to get your client that help. And it is something that we face on a daily basis every day. I currently have 8 clients right now who are pregnant. So, you know, it's something that we deal with every day, and it's something that we don't have the answers for. So, and I know I'm not the only case manager like that. So PCCs are a great help for our team.
Wonderful. And so one last question. Many of the housing case managers say, you know, my job is to help with housing. So why is it important for me to help and support a family surrounding their pregnancy?
I kind of find it hard and difficult for a mom to focus on pretty much anything else if she's having issues with her pregnancy or just, you know, the thoughts about her health. And I feel as though it would be selfish for me to ask her to focus on anything else besides, you know, getting her health and focus and the safety of their baby coming in, right?
Wonderful. Well, I thank you for joining us. Any last words or things you want to share?
Just keep up the great work.
Thank you. And I'm going to turn it back over to Abayea.
Thank you so much, Jamilah and Calvin, for sharing your experiences. And so some of the lessons that we've learned, we have encountered challenges that we've met. We've looked at them, tried to address them. We meet monthly as a team, both the housing side and the health side that are working on this project together. It's important to stay flexible and adaptable as things arise. As Jamilah's caseload has gotten completely full, we've had to adapt and figure out what will happen and how we can continue to serve pregnant participants in the program and beef up some of the education offerings that she is providing. We're also engaging our quality management team to track outcomes across all of our maternal child health programs, including this one. And so those technology barriers that Sara spoke about earlier and how we were going to track data, where that was going to be located, our ability to pull that information so that we can have an understanding of our outcomes has been something that we've been working on together collaboratively. And then as new staff are added to the team, new housing case managers, they need to be incorporated in and have an understanding of how this program can be of assistance to the clients that they're working with. So that education is an ongoing component that we've learned is really important. And then the support that Jamilah provides on an ongoing basis. Her office hours are regular. That was an innovation that she came up with. And so that provides regular support to the housing case managers when they need it. And so now we're going to turn to Dr. Arno to talk about some of the larger context around what it is that we're doing in addressing housing issues during the perinatal period.
Well, thank you, Abayea, and the whole team at Community of Hope. My name is Dr. Anneta Arno. I am the Director of the Office for Health Equity at DC Health. As Chief Health Strategist for the District of Columbia, we are very aware and also very appreciative of the work that Community of Hope is doing, along with several other partners in the city. But what we know is that 80% of what drives all of our health has nothing to do with the doctor's office or any of those other things. It's what we call the social determinants of health. And because of that, and you'll see in the next slide, but don't move yet, you'll see in the next slide that we have a report that we released back in 2019 that really talked about the 9 key drivers of health. And what we actually note is that medical care is just one of those 9. It's not the first and it's not the last. It's the mix of a whole lot of things that come together to produce our individual and collective health. So with that, one of the reasons why I'm partly on this panel is that as the Chief Health Strategist for the District of Columbia, we are really trying to help lots of folks beyond traditional healthcare to understand their critical role, including housing, in delivering health. And especially when it comes down to the intersection of pregnancy and health, and especially housing insecurity and health, that's really where we're kind of learning a lot more. So we don't have all of the answers. And what you just heard from Community of Hope is a really fabulous example of what it takes. So even when you've got all the commitment to do the work and do it together, it's still not just easy to do. So we've got to work. So we are a government agency. Our primary role is in health, but we really have to gather all of our partners across the government to make them also understand how important everything that they do is to delivering on health, and also to recognize that government cannot do it alone. So I have been collaborating with Community of Hope. They've been our kind of learning partner to figure out how we can collaborate. So this diagram that you're seeing in front of us is really showing us that we've got a lot of government agencies, the Housing Authority, the Housing and Community Development, Department of Human Services, Department of Health, and Thrive by Five. We're all doing different kinds of work, but we have to figure out how to connect the dots, because we're dealing, when you have a pregnant person, they're a whole person. They're not thinking about their health in one bucket and their employment in another bucket and their housing elsewhere. And especially when they are in a situation where they're housing insecure. So you heard it earlier, they may not necessarily be homeless. They may be what we call couch surfing. They may be with a family that has extended their housing to them. But once a baby is on the way, especially if they're single, they do not have automatic rights to some housing opportunities in the city. So DC Health went out and got a grant, collaborating with the Pew Charitable Trust to think about the health in all policies approach. So this CASI, Calling All Sectors initiative, is something that we're doing with all of our government partners, but we really want to engage the nonprofit and private sectors to understand their particular role. Next slide, please. So we're really looking at multiple things in terms of housing and health equity. What housing as a social determinant of health. We know, for example, in the District of Columbia, as with the rest of the country, that a lot of where we have housing, how housing is distributed, is really not simply about their structural drivers that even give us what we kind of know in the district. We talked about Northeast, Northwest, Southwest, and Southeast. We all kind of have this image in our heads of who lives in these places, what their conditions are. Those are undergirded by structural issues, including structural racism. And so we're trying to unpack and undo some of those things by moving towards what we call a health in all policy strategy. So this is what the CASI project is about. It's funded by the Pew Charitable Trust, which is a collaboration between the Robert Wood Johnson Foundation and other partners. Next slide, please. So there's a deep connection between education, employment, all of those things around that bucket. And that's what we're trying to do, an equity-informed approach to collaboration in a multi-sector way. Next, click again a couple of times, please. So we're really trying to connect the dots. We've seen what Community of Hope is trying to do, and they're doing it and they're learning from it. And so we may know a lot of stuff, but there's a lot of stuff that we don't know. And the places where we don't know is actually the glue that connects all of these different sectors. So we're thinking about the intersection of housing and housing insecurity in pregnancy. We can talk about these things theoretically, but until you start actually doing it, you don't really understand the challenges of actually making it happen. So we just heard about Jamilah's innovation of having housing work hours and special things to put together, right? So we're trying to do it at a much larger level across the city, across multiple agencies. Next slide. So apart from that, what we've done is we're collaborating through this project with Community of Hope. They're going to be our learning partner. That's what they're going to. They really actually give us an insight into what it is like to be a joint housing and pregnancy care provider. But they're also closer to many other nonprofits in the city who do similar things. So they're going to be working right now. They have a survey out to about 30 different agencies on what we call the continuum of care, trying to learn more deliberatively what the challenges are in terms of connecting those dots between. So they know what they're doing, but is their example and experience the same as other nonprofits or other housing providers? So we're trying to understand that a lot more. We're doing work across many of our government and sister partners that I listed on the first slide to learn about how we as government agencies can work together and do it better. And so that's part of the work. The next thing that we're going to do is start doing what we call resident engagement. So not just talking to the housing providers and healthcare providers. We want to learn from people who are actually experiencing the barriers that they face. So we heard from Calvin, et cetera, that there's some people who readily want to take up this opportunity to have another perinatal care coordinator, but some people are like, no, I don't need that, or I don't want that. Or some of it is it another person I have to speak to? We would like to speak to them and do a survey. We would like to do focus groups, et cetera, so that we're not just learning about how it happens in Community of Hope, although that really gives us a very strong indicator. We want to learn of what's happening across the city and what all the barriers are, and that so we can work as public, private, nonprofits, multi-sector collaborators in improving the system as a whole. So that's really what our goal is going forward. We want to inform, ultimately, that last bullet there is informing policy and practice. We know our mayor is very committed, as evidenced by this conference, to improving maternal and child health. And she's also been talking about not having any mom homeless or housing insecure. So we know collaboratively, we all have a lot of work to do to make that a reality in the District of Columbia. We also know that if it were easy, we would have done it yesterday. And if there were easy answers, we would not have to be doing a lot of this learning, but it's this learning, it's this collaborative learning. What we tend to do at DC Health, we might have evidence-based practice, but we also might have to be a little bit more what we call innovative by thinking about evidence-informed practice. And then sometimes what you're doing is promising practices. So I would say to you that what Community of Hope is doing is absolutely a promising practice. But what they're demonstrating is that we have a lot to learn and to get it to the point where we can call it either evidence-informed and evidence-based. And it takes all of us. As I always say, health equity is everybody's work, and we need all of us involved, regardless. As you saw, almost everybody was covered in those 9 key drivers, right? There's a lot of work for us to all do. And the more detailed you get to look, so you have to not just talk about the intersection of housing and health, you probably have to look specifically, for example, at what it takes for a pregnant person who's housing insecure to really understand what the barriers are. And so with that, I will kind of hand it back to Abayea to kind of let us talk about the questions that may come up from the audience. Thank you so much.
Thank you so much, Dr. Arno. So yes, this is our time for questions. And I think we might have some in the chat. So one question was, is childcare factored into the model? And if so, how? Jamilah, can you speak to any support that you might have provided in helping people to access childcare?
Yes. So a lot of the families that we work with at Community of Hope in the housing program would qualify for the DC's voucher program. So being able to help families through that application process so that they can secure a voucher for childcare, and then also assisting them with finding a location that is amiable to the family, one that's either close to home or work, and things like that. Additionally, for families, it can be a challenge, especially with the reduced number of childcare centers open right now with the COVID-19 pandemic. Just again, doing the research with the family to find the right place for them.
Thank you. Mm-hmm. So another question was, what is the best way to refer a pregnant person who is not a current patient of Community of Hope to the perinatal care coordinator to access assistance with housing? So this is a very interesting question. So the programs that, actually, I'm going to turn it over to Sara. Do you want to talk about how someone can get connected to housing services at Community of Hope?
Sure. This is one of the challenges of our attempts to integrate our models, because housing can refer all of our clients to Community of Hope for health services, but the reverse is not the case. All families in the district who are at risk of or are actually experiencing homelessness go through a central intake location, the Virginia Williams Family Resource Center. And Community of Hope participates in the continuum of care. And so whenever we have a vacancy in one of our programs, the families are referred to us through that continuum. We don't take direct referrals of people who call us on the phone for housing. So Jamilah actually works with people who have already been connected to our housing, as opposed to Jamilah's connecting them to our housing.
And I'll just add that if someone does need to establish care, they can establish care with Community of Hope. And if they're pregnant, they would be assigned to a perinatal care coordinator outside of this housing health integration program. So they would get that support from a perinatal care coordinator. If they do need to be referred to housing support, such as Virginia Williams, the perinatal care coordinator can help facilitate that referral. And so there is a way to get into these supportive services if they are not placed with us for housing.
And I can add a little bit on a broader scope. All family housing services are delivered through Virginia Williams. What we do know is that if it's your first pregnancy, you are not automatically eligible for family housing. And so some of the work that we've been doing through the CASI initiative is to really figure out if there may be some other strategic ways that we can assist with that process, because the current rules are not necessarily, again, nobody deliberately designed the system in the way that it currently exists. That's largely because we developed our housing policies separate from our health policies, separate from our Medicaid policies. What we're trying to do right now is to connect a lot of those dots so that we are treating a whole person, and that are similarly, just like they can do some referrals inside of Community of Hope, we're trying to do a better job of doing referrals and being more sensitive to the unique needs of pregnant people when they're pregnant in their first and second trimester, when they may not be fully eligible for all the services that might be available in the city.
That's great. Thank you. And so then another question is, are we inviting the housing leaders within our communities to join in on our maternal infant health conversations? Are we effectively communicating with these leaders how housing instability impacts maternal infant outcomes?
Well, I'll answer it quickly. That is exactly the purpose of this project, right? So what I've learned, and so for me, it's learning. So we created the first health equity report for the district in 2019. We really lifted up that concept of this 9 key drivers. But what I know is I can yak and talk about these things conceptually, but until the rubber meets the road, where you're sitting down and talking about your policy in your shop and my policy in my shop and somebody else's policies, we're never going to really fully understand how one is not necessarily supportive of the other. And everybody's going forward in their separate policy silos, and I'm going to call it that, with good intentions, but with blinders on and not understanding, as I call it, the whole person. And that's why DC Health has really ventured into trying to connect the dots. And so we've put together this working group with Community of Hope now joining us, and then now going out to try to understand not just singularly what's happening at Community of Hope, but also with all of the other nonprofit and private sector partners, so that we come up with something. And we may not solve the problem the first time. We know every time you put in a new solution, you may create a little bit more noise in the system, but it's with a long-term vision for closing the loop and improving the outcomes. And so that's how you actually learn and improve processes and systems. So yes, the answer is clearly yes. We are making sure our housing partners fully understand their role, whether they're in the private or the public sectors.
Thank you. Another question is there a ranking of factors of health? Where would housing fall? The context is very helpful.
I would not rank them. There's a deliberate reason why we put them in that circle and they're overlapping. And for everybody, it varies, right? So somebody at a particular income may be able to afford X housing, but if they earned a little bit more, they might lose their housing voucher. So it's very complicated. But what we do know is that housing is one of those basic needs. It's like food. You have to have somewhere to live, or you are going to be exposed to a whole lot of things. So there's no ranking. We know that to have a really good quality of life, you need all of those 9 things. You need, if you think about Maslow's theory of hierarchy of needs, yes. And then you also need, all kinds of other things to wrap around to have a secure environment in which to be birthed. So we heard from other presentations in this conference about how important it is even before you're pregnant. But even after kids are born, they need an enriched environment in which to live. And we can actually have we pass on good quality living environments throughout the life course. So that's the other thing that we are committed to, is the concept of life course, from pre-birth all the way through to when we kind of return to our maker.
And I would just add a little bit for our internal processes. We do a risk stratification that looks at a number of factors, and that helps us to determine how much contact or how much outreach the PCC will need to do in engaging the patient. It determines how many visits she provides or contacts that she provides. And that is the risk stratification takes a number of factors into account, one of them being housing, but many other things as well. It could be the experience of depression or other mood disorders. It could be perhaps substance abuse. It could be having low social support. And then also some of those factors could be a previous preterm birth or a previous low birth weight baby. So we do take all of that into consideration in forming how much support we estimate that this particular participant will need. But again, we can't really, all of these things, as Dr. Arno said, are factor into the experience that each of our patients or participants has. And so another question came in. Can you talk about the resistance that people have to having to share their stories to too many case managers? Jamilah, could you speak to, have you had that experience where you've encountered resistance at all?
So I have not directly, but I have heard from case managers that are supporting pregnant families. When families have higher levels of social needs, then they generally have more people supporting them from outside their family. And so for some families, adding another person feels good, like I have more support. And for other families, it feels like there are too many people that know everything that's going on in my life. There's this presumption of privacy that they want. They don't want the whole world to know everything that's going on. And so adding another person to them feels like too much. That's kind of the perception that I received from case managers. And I don't know if Calvin wants to add anything to that, but that's just kind of what I've heard.
I can double down on that as well. That's pretty much the only time that I see it, when it becomes to be the point where it's too many people on a case. You have 1 or 2 mental health case managers. You may have a housing case manager. A lot of families may have a CFSA caseworker, and you just start to pile on. After a while, it's just like, I don't need anyone else. And sometimes we do get that, and sometimes just clients who've had 3 or 4 kids and maybe feel like, hey, I got this down to a pack, I got it down to a science, I don't need any other help. Those are some of the only times I really see pushback.
And I would add that many of the times that we have all of those caseworkers, et cetera, it's because the way we've set up these systems. So some of it's structural, right? They've been put in place primarily to be gatekeepers, right? And again, all of the different systems put up their system with their blinders on without reference to how the individual at the center of this may feel about what this impact is. And so I think, you know, a lot of us who are in these kinds of programs, we are trying to do, we think we're doing good, and we probably are, but we set them up in a way that it does not necessarily feel very caring, or it could not feel very caring to the person who is the recipient of it, despite our good intentions. And so I think that's a lot of why we are thinking about it in a much more structural and systemic change way, by thinking about it through a multi-sector health and all policies approach, including the mental health of the individual and the family, that we should take into account as we consider that. So I think it's really commendable that Community of Hope is doing this work and trying to learn more from when you put these things together, and not declaring that it was just easy, right? Because we know it's not. It's not easy to change these systems even within an organization, and doubly hard across the system. But we at DC Health really appreciate their collaboration in terms of working with us on the Calling All Sectors initiative.
Thank you. So I don't think we have any other questions, but we do have a little bit of extra time. So if you don't mind me putting you on the spot a little bit, Jamilah, can you think of a story that you would just like to share about how you have supported a family, of course, without sharing any of their information, but I think that might help just round out and give a full picture of what it is that you're providing.
I think one of the stories I would like to share is a family that I worked with in the prevention program. And she was having some challenges with her housing that caused her to have to stay with family for a while and be rehoused. And so because she was in the prevention program, the families in the program tend to be there for a very short amount of time. And so the case manager and I were able to organize all of the support and things that the family needed for their transition to a new home in just a few weeks. And so it took a lot of effort from both of us to ensure that the family had everything they needed. There were several items that in the family's home that needed to be replaced. So we were able to connect them to resources to get that done. And we got it all done. The case manager was able to help her get into a new apartment, and I was able to help connect her to resources to get new furniture and a new pack and play for baby. And it just felt really rewarding to be able to make sure that the family had everything they needed before they were exited from the program. And, you know, just kind of being able to support them in that was really good.
Great. Sounds like rapid fire action. So.
It happened really quickly, but it all worked really well.
Great. I'm glad that you all were there to support that family. All right, well, there are no other questions, so we can probably end here. Thank you so much to Dr. Arno, to you, Sara, to Jamilah, to Calvin, to all of you all for bringing this presentation to us and helping us understand more of how this integration and work can be done. Oh, sorry. One more question before we end. How can people get more involved with CASI? How can we spread the word?
Okay, I think that's coming my way. In fact, I'm going to ask one of my colleagues. I think we're going to share it in the chat. I'm not sure if it's in the chat or wherever. I think there's a portal that we can put in. There's a flyer on that. But I think right now we're sending it out individually to a list that we have of 30 30 organizations in the continuum of care. When we get to the point where we're talking about resident engagement, we'll do another round of learning more about who's interested, et cetera. But if you wanted to send an email to me, my email address is Anneta, ANNETA.ARNO@dc.gov, and we'll be sure to send you any more info as the process rolls out.
Great. Thank you so much. Oh, one more, sorry, I think.
What financing needs are most critical to advance this holistic approach for Community of Hope and other providers? They're asking Community of Hope, so I'm thinking.
Yeah. Sara, would you mind speaking to, says the last one. I know that we are generously funded for this for several years. Do you mind speaking to that a little bit?
I can speak to our current status. We did have a 4-year grant that allows us to really experiment a bit with continuing to expand and improve upon all of our housing programming for families. And this is one of the positions funded under that. I'm a social worker, not a finance person, so I know that I don't know if there would be beyond, but so that continues for at least another couple of years. I don't know about billing with under insurance and that kind of thing going forward. I think would be one thing that we'd be looking into.
Yeah, and I will continue, and we at DC Health will continue to do what I say is health equity is everybody's work. And so frequently what we talk about at DC Health is that not that you need brand new money. Sometimes you need to change the system so that the system and the money that we're already spending is more effectively spent to do the work that we know would be better in improving health outcomes. So a lot of what we're doing in collaboration with Community of Hope and our other partners around is talking about, so part of the work that we're doing has included DC Healthcare Finance to do some more research to understand how perhaps we could think about how much we are quite apart, if you want to talk the financial side. Yes, we're really focusing on health, but we are probably losing a lot of money that we're spending in other ways that could be more beneficially spent if we spent it in a way that is more supportive of health, to help mothers and children, because as I talked about earlier, we're talking about a life course. If we don't provide every single child who's born in the district with a strong start, we will not come out at the end of it with really healthy children who become the next generation of healthy parents, et cetera. So I think that's how we have to think about it in a much more holistic way. It's not always about more money. It's about a better approaches to gaining the outcomes that, we've been throwing money at a lot of problems without necessarily fixing the systems that we know could do better for all of us.
Okay. Thank you, Dr. Arno, and thank you, Sara.
I will add one more thing, which is I think that one of the learnings from this is that while we treasure having Jamilah services available to individual families, as she and Calvin described, there are a number of families who say, thank you very much, but I'm going to pass. And a very large part of what Jamilah has helped us with is to provide, as she said, basic information to our case managers to increase their comfort level with even broaching the topic of pregnancy and talking with families about what resources might help support them in that and connecting them to those, even if it's not a Community of Hope. A number of our housing families get healthcare at other locations, and they're just opening up the comfort level and the knowledge base to be able to ask just key questions and make sure that visits are happening and that services are available and that families are being connected, just kind of broadening their focus. And that doesn't cost a lot. I think that one of the things, just educating our staff and building in those opportunities for learning has also gone a long way.
Okay, thank you. So I do think that was the last question. So thank you so much to all of the panelists for your participation and highlighting these important efforts. So thank you.
Thank you.